صباح الخير، أنا اسمي أماني علي وهكلمكم النهاردة about challenges in toric IOL calculation. So, the 5 keys to astigmatic planning success are to consider the posterior capsular astigmatism and use the Barrett calculator, to input surgically induced astigmatism centroid value of 0.1, and to aim for a target refraction post-operative 0.34 with the rule astigmatism to make up for the long-term drift into the against the rule astigmatism, even if I'm going to flip the axis. And please take care of patient refraction. So, toric IOLs are astigmatic correction IOLs that have different powers and different meridians. It is indicated in with the rule astigmatism of more than 1.5 diopter and against the rule astigmatism of more than 0.4 diopters. They are available as monofocal and multifocal IOLs. Preoperative assessment, I have to be very quick. I have to check the patient glasses and refraction. لو سمحت. Okay. I have to use multiple sources of information like the autograph, the topography, and the IOL Master. I use the IOL Master 500, which is a non-contact partial coherence laser interferometry, and I have to make sure that I collect detailed data, right name, laterality, and type of surgery that the patient is going to be subjected to. I have to take detailed history of silicone oil or laser correcting vision, or aphakia or pseudophakia, and all of these things can be inputted into the IOL Master. I have to measure the corneal curvature, axial length, AC depth and effective lens position, white to white, and the new IOL Master 700 uses swept source OCT and measures also the central corneal thickness and the lens thickness, and some machines with the new TK technology have the posterior curvature as well to count for the total keratometry. Then I use the IOL calculation and formulas. The challenge, دكتورة أسماء اتكلمت عن axial myopia. I'll only talk that the scarce powers of IOLs for high myopia, and most powers start from range of +5 and the myopes need less than that. And the higher incidence of toric IOL rotation due to the wide capsular space and the wide to wide diameters. Corneal curvature, the IOL 500 measures the anterior corneal curvature while the 700 measures the total CK. I have to make sure that the patient takes off their contact lenses to avoid myopic shift, and I have to give artificial tears in very severe dry eye. So I use topography if the standard deviation is more than 0.03. There's a difference in axis readings more than 10 degrees as we see on the right here, diagrammed in yellow. And if there's a difference of more than 1 diopter between both eyes, if there is previous correction, laser correction surgery, corneal opacity, severe dry eye, or keratoconus. Now, as a reminder, posterior corneal astigmatism. What is with the rule astigmatism is when the steep meridian is vertical, and that's present in most young population. Against the rule astigmatism is when the steep meridian is horizontal, and that's in older, our cataract population. So the cornea is steep posteriorly, and it acts as a minus lens. And if it's steep vertically, like in 87% of the eyes, it acts as a low-powered lens in the back of the cornea that is creating plus power along the horizontal meridian, that is to say, against the rule astigmatism. So if it has against the rule on the back and steep vertically on the front, then the total corneal astigmatism actually ends up being less. But if it's steep horizontally on the front, then the total corneal astigmatism actually ends up being more. So the magnitude of posterior corneal astigmatism increases with higher amounts of anterior with the rule astigmatism, and overestimation happens, and it stays relatively constant with higher amounts of anterior against the rule astigmatism, and there's an underestimation of 0.3 diopter. I can measure it directly by Scheimpflug topographers like the Pentacam, LED topography like the Cassini system, or swept source OCT like the IOL Master, or I can estimate it by theoretical formulas. The Baylor Nomogram is based on population average for posterior corneal astigmatism. It requires integrated data from multiple ocular tests, and it makes adjustment for the with the rule against the rule. And it aims to leave patients with light with the rule astigmatism to account for the against the rule shift that occurs over time with aging, and it adjusts the effective toric power of the lens. This is how the nomogram looks, and the Technis toric calculator employs the Baylor Nomogram for prediction of posterior corneal astigmatism. Now for the AC depth is the distance from the anterior corneal epithelium to the anterior length along the visual axis. There are a lot of errors in measuring in pseudophakic eyes. effective lens position. Dr. Shireen thankfully was very detailed, بس أنا هقول نقطتين. In reality, two eyes with the exact same axial lens and K power may actually require totally different IOLs. That's because of two different variables: the effective lens position, or the distance of the lens from the cornea, and the IOL geometry and the lens model. So as she said, it is the distance between the principal image plane of the cornea and the principal image plane of the IOL. For surgically induced astigmatism, it is affected by the incision location and size, the preoperative astigmatism degree, the patient age, and the use of sutures. Corneal phaco-incisions induce flattening when they are placed, and the corneal coupling effect, if one meridian is flattened, then the corresponding meridian 90 degrees away will be steepened by the same amount. So from that, we deduce that temporal phaco-incision reduces against the rule astigmatism, because steep meridian is horizontal. I will use flatten it by the incision, and so it will get less. But with the rule astigmatism, I am steepening the already steep meridian if I use a temporal phaco-incision. So it will get worse. So the surgeon has the challenge of changing his position, and it's a problem for deep-set eyes, overarching brows, or tight palpebral fissure. Now, for the centroid surgically induced astigmatism, centroid means a point where there is equal volume on all slides. And the centroid value takes into consideration the direction as well as the magnitude of the surgically induced astigmatism. We can measure it using the Dr. Hill calculator or the Holiday formula, or I can just simply put 0.1 diopter. In a study done in April this year, magnitude of surgically induced astigmatism centroid gave far less than using the mean surgically induced astigmatism. Now, for the formulas and the online calculators, as Dr. Shiri kindly noted, the Barrett suite, I use 5 formulas: the Barrett Universal, the Barrett Toric, and the Barrett Toric True K for post-laser correction surgery, and the Barrett Rx for IOL exchange and piggyback lenses and re-rotation of the IOLs. I can use the Haigis suite with the Haigis Toric, or the Kane and the Holiday 2. These are the most effective in calculating the toric IOL. Here's a list of good websites. Most important of which is the Ascaris calculator and the Asia Pacific. So the Barrett calculator accounts for the posterior corneal astigmatism, calculates the patient effective lens position, recommends toric IOL power with the least residual astigmatism, and used a centroid value for the surgically induced astigmatism. Here's how it looks. Notice the predicted versus the measured corneal astigmatism. And here's the with the IOL calculated power. And here it can take up to 3 different integrated K values from 3 different machines. This is the Barrett True K calculator following LASIK and refractive procedures. And this is the new shape of the Alcon Toric calculator that employs the Barrett formula. The old one used to have fixed ratio of 1.4 diopters and calculated the corneal vector. And that's the outline for the Kane formula. So for long-term drift, it is known that in most people in the anterior cornea only, with the rule astigmatism will drift to against the rule at an average rate of 0.35 per decade. So we have to aim for post-operative with the rule residual astigmatism of 0.3 diopters. It's very important to peek at the patient refraction, because if a patient has a significant refractive against the rule cylinder and very minimal K reading against the rule cylinder, then we should expect extra posterior corneal cylinder and choose a higher toric IOL power to treat it. So now we say that axis flipping is perfectly okay, but before we were under the assumption that patients would be unhappy if I flipped their axis. So earlier calculators recommended IOLs that left more residual cylinder to avoid flipping, but it's actually tolerable and preferable. And we shouldn't flip with the rule astigmatism, as we want to leave some residual. Higher power IOLs have greater toric effect. So even if the toricity is identical. So if I use the same IOL, but if it's higher it will give more toricity. So if I implant an IOL and post-operatively it rotated, how would I know if this IOL needs to be re-rotated or just taken off? And I can do that as astigmatismfix.com. It tells me if I need to re-rotate and the exact axis of re-rotation, or if I need to take it off. Also, the Barrett Rx formula for piggyback and lens exchange can give me a rotation number for the toric IOL present. The go-home message is to use the Barrett calculator and peek at the patient refraction, use a 0.1 centroid factor for surgically induced astigmatism, and target residual astigmatism of with the rule of 0.34, and use it for with the rule more than 1.5 diopter and against the rule of more than 0.4. And of course, thanks to Dr. Hill, Dr. Barrett, and Dr. Koch, this is the age of astigmatic enlightenment. Thank you.